diseases that are affecting the cardiovascular system and the lymphatic system. The cardiovascular system is like the pipeline of the body, and the lymphatic system is going to run fairly parallel to that, as we'll see. The cardiovascular system is composed of blood vessels, the heart, capillaries. All of those vessels are going to fall under blood vessels, and it's going to function to carry all of the components that the body needs. We're going to carry oxygen. We're going to carry red blood cells that are carrying that oxygen and picking up carbon dioxide. We're going to carry nutrients, hormones, proteins, sugar. Anything that your body needs has to have a mode of transportation. It also will carry some waste products, although that is primarily going to be for the lymphatic system, for the largest part of the body, and then carried over. Although, like I said before, carbon dioxide, that's a waste product that is carried by the cardiovascular system. And so the blood vessels will carry everything. They're like the highways, and the heart is the pump that helps them to move. Okay, it helps that blood to move all the way around the body. And this is what we call a closed circuit. It's not going to wind up opened, and everything is going to stay within that particular circuit. As you can see in the previous pictures, the lymphatic system runs very similarly to the cardiovascular system. It is one way, however, instead of bidirectional. It is composed of lymphatic vessels, nodes, and those lymphatic vessels. Sorry, I was going to say capillaries, same thing. And so the function there is one, to carry that waste tissue, to act as a filter. Okay, to act as a filter, and it's going to kind of scan that filtrate and look for foreign invaders. And so it has a big role in the immune system. It carries the immune cells. All right. So the lymphatic system, we're going to have the spleen. You're going to have the lymph nodes, which are all over, but we do have large clusters of them. And of course, as I said, it runs pretty much parallel, intertwined with the blood vessels, so it can transfer things in and out from the blood vessels from the cardiovascular system. Carries those immune cells, which are usually going to be antibodies, white blood cells, those types of things. And again, it is one-way passage. It's going to collect the fluid from the tissue, filter it, and scan it, and then send that back to the cardiovascular system. So here you can really see how the cardiovascular system runs very closely parallel, and there are many more smaller vessels that are not included on here. You could lay this on top of here and see that it does run parallel, okay? You can also see here that while the cardiovascular system runs two ways, the lymphatic system is going one direction, all right? And so let's see. We have different body compartments, and body compartments are going to be screened by circulating white blood cells in the cardiovascular system. The lymphatic system has all these branching networks here of vessels that are extending into the body areas. You're going to see here a higher density of those lymphatic vessels in the dead end, so to speak, areas like hands and feet. You notice all the green there in the hands. And also areas that, breast also, but areas that are frequent contact points for infections, all right? We also have the spleen. There is also some gut-associated lymphoid tissue, that's GALT. The thymus and the tonsils also act as part of the lymphatic system, okay? On the right, you can kind of see they're compared here in the direction, one being bidirectional and the other being unidirectional, okay? And so these are going to connect near the heart, where a large lymph duct is going to empty the fluid into the veins, all right? Anyway, okay, so you can see, it's a little harder to see in this picture, maybe if you look close up, but you can see the groin area has lots of lymph nodes here. You're going to have many in here, the axilla, lots here along the bottom of your jaw, okay? And so there's some better photos for us to kind of show you where those are, but that's really more important for something like anatomy than in here. We apply it in here. All right, so your heart is roughly the size of your fist, all right? As long as it's healthy. If it's enlarged, that's not a good state. It shouldn't be enlarged. You've got 4 chambers in your heart. Remember, when you are looking at a patient or a diagram of the patient, your right and left are going to be swapped. So here we're going to have the right atrium. The atriums are on top, and then you have a right ventricle here on the bottom, the left atrium, and then left ventricle. You're going to have these valves. We're going to have the bicuspid. We're going to have the tricuspid valve. There's 4 valves totally, or total, sorry. Bicuspid, tricuspid, then you're going to have the right semilunar and the left semilunar, and some of these have different names. Okay, we won't get into these too much. And so the ventricles are basically kind of holding chambers. You've got the tissues of the heart. We've got the pericardium, peri meaning around, and so this is the fibrous covering of the heart, and sometimes this does get infected, and that would be pericarditis. Then we have the epicardium. Epi means above, myocardium, endocardium. Endo means inside. Okay, so those 3 layers make up the pericardium, basically. Okay, let's see. All right, so we've got our some definitions here of our arteries and veins. The layers of blood vessels from the innermost, they're going to be made of endothelium, and you're going to have a smooth surface that encourages the flow of cells and platelets. If it's not smooth anymore, those platelets and red blood cells can get caught up and cause clogging up of the arteries, which is not a good thing. The middle layer is going to be also connective tissue, but some muscle fibers, and then the outer layer is a thin layer of connective tissue. So arteries are going to carry oxygenated blood away from the heart. There are some exceptions to the artery and vein rule that we learned in anatomy. The ones that start with pulmonary are backwards. So the pulmonary artery is actually kind of a vein, and the pulmonary veins are more like an artery. Okay, but otherwise, arteries carry oxygenated blood away. Veins carry deoxygenated blood towards the heart. All right, arteries are going to have a very lot more, I should say, higher pressure than the veins. They are carrying oxygenated blood away, and they have to go all the way throughout the body. Okay. Whereas veins are going to be carrying the blood back to the heart. They don't have as much pressure. Capillaries are going to be very, very small, usually 1 red blood cell thick, okay? And they only have 1 layer of endothelium. Well, that is important because we need to be able to get the stuff from inside the blood to the tissues where it needs to go. And so if we're going to do that by diffusion, say, you need a thin surface to diffuse across and to facilitate that. So the cardiovascular system has a lot of protection from microbial infection. So microbes are going to invade the system, or when microbes invade the system, they have an access point to every part of the body. So that's why when something gets in the blood, you get so sick, because it goes all around the body. So you really have to have a lot of protection from microbes surrounding this particular system, okay, because it can affect every other system. Bloodstream infections are considered systemic infections. We have 5,000 to 10,000 white blood cells per milliliter of blood to help protect us. Lymphocytes are, remember, part of that specific immune system. And then we have those phagocytes, which are going to be both specific and non-specific. Okay, so definitions are always really important, and we kind of use these a little bit somewhat in everyday language, but we maybe throw them around a little too easily and not differentiate, but it's very important to understand the difference between these. Any condition involving the blood is going to end in emia, okay? And so once you understand that the emia means the blood, then it's kind of easy to figure out the rest of the definition. So viremia, of course, is going to be viruses in the blood, or virion, I should say, in the blood. Fungemia is going to be a fungi in the blood. Bacteremia, bacteria in the blood. Septicemia, or sepsis, is going to be when the bacteria are now growing and flourishing. They're not just in the blood, they're actually multiplying, and that's a really important differentiation there. And then septic shock, which is also sometimes called sepsis. Like I said, we kind of throw those around loosely. This is where you have this cascade of events that causes you to go into shock. Basically, you lose your blood pressure. You sometimes can go and throw clots around, especially if you get into disseminated intravascular coagulopathy, all right, DIC. And so this is really bad. This is when everything is going to start shutting down. You're going to have major need for intervention here. So like the nervous system, the cardiovascular and lymphatic systems are closed systems. So there's no normal access point to the external environment. Like our respiratory system, we have all these openings, all these mucous membranes, okay? So there is no known normal biota in the absence of disease, all right? So microbes that may be transiently, which means temporarily present in either system, but the lymphatic system is supposed to filter and catch those products and get them out of the tissues. So in a healthy state, there are no microorganisms that are normal microbiota. They should not be colonizing the lymphatic or the cardiovascular system like we see in some of our other systems, like our digestive system. So we're going to start with malaria, which is a problem worldwide. This is a pretty important one. In class, we will learn, when we're on campus, we learn this life cycle and use it as an essay, okay? And so while we don't do essays online, you do need to know the life cycle for malaria and the life cycle for Plasmodium, toxoplasmosis. Sorry, Plasmodium is the parasite for malaria, and I was trying to say Toxoplasma gondii instead is what I was trying to say. Anyway, so you should know the life cycles of these two because they are really important, especially malaria, because this is a chronic worldwide issue, okay? I don't necessarily mean a chronic disease, although it can fall into that. I'm just saying it's a big problem in a lot of areas. So this is transmitted by a vector, which is the mosquito, okay? It has a complex life cycle. It has both sexual and asexual phases of development. You're going to see, well, let me stop here for a minute. There are many species, up to 200, but the ones we usually see are going to be Plasmodium vivax, Plasmodium falciparum, ovale, Noelisi, and Malariae. All right, those are the common species that we see carrying mosquitoes, all right? And so the development of the parasite is divided into that asexual phase, which occurs in the human, be sure you know that, and the sexual phase, which occurs in the mosquito. And so you're going to have merozoites that are going to go into the red blood cells and cause them to release fever-inducing chemicals, cytokines, into the bloodstream, okay? And then as a result, you'll see some chills and fever that can occur kind of in a cycle, in a cyclic pattern, all right? Plasmodium is also going to metabolize glucose at a very high rate, and so you will often see hypoglycemia as well. And then if you are damaging and rupturing, when those merozoites leave, they rupture the red blood cells, it's going to, of course, cause some anemia, so that could be another symptom as well. And so you can accumulate products of this malaria disease in the liver and in the immune system, in the simulation in the spleen can cause both of those to enlarge, okay? So you can see liver and spleen enlargement. And so this also can affect the red blood cells, or the blood vessels, I'm sorry, in the brain. So pretty virulent disease. So those cyclic bouts of fever and chills are going to be caused by the lysis, or rupturing of those red blood cells. We're going to have a 10 to 16 day incubation period. You'll see fatigue, malaise, aches and pains, and nausea, occasionally some diarrhea, and then you'll see those cyclic fever, chills, and sweating, those cyclic bouts, okay? These symptoms are going to occur within 2 to 3 days, every 2 to 3 days, because of the red blood cell rupture. The interval and length of these symptoms can reflect the type of malaria. So falciparum malaria, you're going to have a persistent fever, cough, and weakness for several weeks, okay, without much relief. You can have complications like hemolytic anemia from the rupturing of the blood cells, organ enlargement and rupture because of cellular debris, extra white blood cells. Those can all accumulate in the spleen, the liver, or the kidney. If you have cerebral malaria, this can be one of the most serious complications of falciparum malaria. The small blood vessels and capillaries in the brain become obstructed due to those red blood cells adhering to the blood vessel walls. Like I said, capillaries are usually one red blood cell in width. Okay, and so that's going to cause some ischemia or a decrease in blood and oxygen flow in the brain, which we cannot tolerate for very long. So that can cause a coma and even death. So in general, malaria is going to have the highest death rate, of course, in the acute phase, especially for children. Malaria caused by Plasmodium vivax and Plasmodium ovale are subject to several relapses later on because some infected liver cells can actually harbor the protozoans for up to 5 years. Now, why does, oh, sorry, I'm getting off topic here. Hang on. So here is the life cycle of the Plasmodium, the parasite that causes malaria. This isn't my favorite illustration, although it is kind of simpler. So I don't know, it may grow on me, but we're going to use it because this is what's in our textbook. So we're going to start out as a here at number 1, and remember this is a cycle, so you can kind of pick up anywhere in the cycle, and you have to have both hosts in order for this life cycle to be completed, both the mosquito and the human being. All right, so you're going to have a sporozoite that the mosquito is going to bite and pick up. That will be the asexual phase. The female pregnant mosquito of the Anopheles mosquito injects saliva that's going to have an anticoagulant. It's going to prevent your blood clotting in the capillary, and that's going to allow her to get a blood meal, but in the process she is going to inoculate that blood with the sporozoite. Okay, sporo means seed, and zo generally refers to animals. So that's the form of the larva. All right, and so there's several larval forms here that have these weird names. So sporozoites then are going to circulate through the body and migrate to the liver. All right, you can see that by the blue arrow right here. Okay, and so they're going to migrate to the liver in a very short period of time. In the liver cell, these sporozoites are going to undergo asexual division, and we call that schizogony. Okay, schizo means to divide, and ogony or gon means seed. And so this is where you're going to generate many daughter parasites, and we're going to call those now merozoites. All right, so the merozoites, this phase is going to last 5 to 16 days, depending on the species of Plasmodium, and it's going to end when this is going to rupture. This merozoite here cell is going to rupture and release 2,000 to 4,000 merozoites into the circulation. Okay, so they're going to bust out of this particular cell and be released of the schizont and be released into the circulation. Okay, and so now they're in what's called the erythrocyte phase because they're going into the red blood cells. And so the merozoites are going to get into the red blood cells via a receptor, attaching to that receptor, and then convert into what's called a trophozoite. So they're kind of wormy shaped here, and here they're circular, so they look a little bit more like a cell, okay, a ring. So that's a trophozoite. So during this stage, they're going to feed on the hemoglobin and get larger, and they're going to again divide and produce another cell called a schizont, where they're going to have they're going to be filled with many they're going to divide many times, produce the schizont, and they're going to have even more merozoites. Okay, and so the red blood cells are going to, or trophozoites, the red blood cells are going to rupture, okay, and let these go, and then they're going to differentiate either into female or male versions of these gametocytes. Okay, that's just another larval stage. All right, and so the human doesn't provide a suitable environment for the next cycle. What's going to happen is another mosquito will come and pick up the blood. All right, and so this is going to be the sexual phase. All right, and we're going to call this sporogeny, and that's going to occur when a mosquito draws out the red blood cells as she is eating, and in the stomach, those male and female gametes or gametocytes can be fertilized. Okay, And so then it's going to be diploid, and we're going to have a ookinete, and that's going to be in the mosquito. It's going to become an oocyst and undergo mitosis. Okay, so like I said, it's kind of complicated. Sporozoites, merozoites, and gametocytes, those portions are important. You need to know kind of which phase occurs in the mosquito and which occurs in the human. But the real details, further on than that is beyond what you need to know. Okay, so that's going to complete one sexual cycle and an asexual portion of the life cycle, going from one to the mosquito to the human and back to the mosquito as a whole cycle. So I think I already kind of told you all of this on a different slide, except maybe the individual protozoa are going to have different antigens, okay? Just as each of us people are different, they have a little bit different antigens on their surface, which can make it difficult for our immune system to be able to battle it, because you're not getting one antigen to fight. You're getting all these hundreds and thousands of different antigens. So it makes it very difficult for our immune system to deal with, okay? And so this is going to be spread by the female Anopheles mosquito. Malaria used to be distributed all over the world. It is mostly just in the temperate areas now, kind of a belt around the equator. We have 200 million new cases every year. 90% of those are in Africa. This affects mostly children and young adults, and we have a death rate of about 500,000 to 1 million every year. Okay, in the U.S., the rate is about 1 to 2,000, which is primarily due to differences in climate. All right, so a concern for this is, as we have increased global warming, the climate regions may change, and so the equatorial region may expand, and so you may see malaria in areas where it used to not be before. Now, one interesting component or part of malaria is a person that has sickle cell anemia may have a resistance to malaria depending on if they have sickle cell trait, which is really quite interesting, and is why we still see sickle cell anemia in the population, in the gene pool. Okay, so if you have one gene for sickle cell anemia, you have sickle cell trait, and if you have two, you have sickle cell anemia, which is much worse. But if you have the one gene and you have sickle cell trait, that is going to give you resistance to malaria, and so that resistance to malaria allows that trait to be passed on, because these people are surviving at a higher rate because they don't catch malaria when many other people do. So just kind of an interesting tie to sickle cell anemia here. All right, so diagnosing malaria is going to be by finding Plasmodium in a blood smear. And we do look at slides of this in the lab. I don't think we have any of these on this particular online lab, but it's pretty interesting to look at and pretty easy to tell when you see these little worm-looking things in the blood smear. Okay, other indications are going to be getting that patient history and finding out if they have traveled. And so it seems like all these questions are kind of intrusive, but really they're very, very important. Have they traveled anywhere? Where did they go to? Have they had fever and chills and sweating? And so how do we prevent it? Well, that's going to be by preventing the mosquito from biting you. Getting a mosquito net around the bed. You're going to use insecticide. Eliminate standing water. If you're traveling from the U.S. to a country where malaria is, you can often take a prophylactic drug. There are also a lot of things to looking at decreasing the mosquito population, even through genetic engineering. All right. Let's see. I don't think there's anything else here. All right. In 2016, we did come up with a vaccine for malaria. It's called RTS. All right, this is going to be effective against Plasmodium falciparum, which is the most deadly and most common strain found in Africa, which is where we said we found 90%. Right, so this is a huge, huge discovery. They piloted this vaccination program in 2018. Other than that, we have long time used quinine, all right? That's been a mainstay of malaria treatment. chloroquine is used for non-resistance forms because it's less toxic than straight quinine. Not that this is a terrible thing for you. Again, it's with any medication, it's a cost-benefit analysis. Okay, what is the risk of harm to the risk of helping? All right, and so the protozoa itself has actually developed resistance to almost every drug. Okay, just like any other microbe, while this is not technically a microbe, it does have a microscopic part of its life cycle. Resistance is a big problem. Okay, we have some plant compounds, artemisinin, that have been used and effective as well. But usually we're going to use this in a combination with other medications to prevent resistance. All right, so now we're moving on to HIV. HIV is in the genus lentivirus. It is a retrovirus, which means it can take its RNA and convert it to DNA. Okay, it uses reverse transcriptase to do that. Lentiviruses produce really bad, very often fatal diseases that can alter the host DNA. So this is a tough group of microbes. And so it takes that double-stranded, single-stranded RNA and makes double-stranded DNA using reverse transcriptase. Okay, so that's what a retrovirus is. And so it can actually integrate the viral genes into the host genome, and then that can be passed on to other cells. So some retroviruses actually transform cells or make them malignant. Okay, so HIV has a kind of a Trojan horse way of entering the cell, and we may go over this again, but I want to do it while I'm thinking about it. It attaches to the CD4. In fact, I think there is a slide on this, the CD4 receptors, and that allows them to gain access to the cell. So the CD4 receptors are there for something else, and HIV kind of mimics that, all right? And so then it gets into the cell, and you'll have an initial infection that's kind of flu-like or virus-like in nature. And then it sits latent in host cells and can enter the nervous system tissues, okay? So it can cause an immunodeficiency. And so your symptoms of HIV are going to be tied directly to those two things. One, the level of virus in the blood. And two, the CD4 T cells. The T cells in the blood are going to fall below 200, and that is when you are diagnosed with AIDS, acquired immune deficiency syndrome. So HIV is going to cause the disease AIDS, acquired immune deficiency syndrome, and that is when you get to a level of 200 cells per cubic milliliter, but 200, your T cell count gets below 200, and that's when you basically have lost a good portion of your immune system, okay? And so you can get these repeated opportunistic infections that you wouldn't normally see in a young, healthy person. When this first came to the United States, I remember when this first came through in the early 80s, it hit the news, and they were calling it gay cancer. They didn't know what it was. And while it's predominantly in the heterosexual population worldwide, when it first came into the U.S., it kind of entered into a homosexual community with a bunch of young men, and they were the ones that were getting really, really sick and having these opportunistic infections that a young, healthy man who's 20s should not have. And it took them a while to figure out what exactly was going on. While it can cause cancer, it's not exactly cancer. It's this virus, all right? Of course, many viruses can cause cancer, but they were seeing these things like pneumocystic pneumonia, where you have fungi in your lungs that you don't get when you're 20 years old, all right? And so lots of these things, and those were actually very important in helping them to diagnose and figure out exactly what was going on. It was a very scary time. Nobody really understood what was going on and why these young men were getting sick, okay? And it took us a while to kind of figure that out. And so you get these opportunistic infections. You can also get other symptoms related to having a deregulation of your immune system. You get hormonal imbalances, metabolic disturbances as well. Your body muscle mass can waste away. You can have chronic diarrhea, so you don't absorb nutrients. You get lesions in the brain, your spinal cord, meninges, and even your peripheral nerves, and many, many other things as well. So let's look at the progression of HIV, and this is without treatment. We've actually come very far in the treatment of HIV. It used to be only a few years that you would live, and now people are living a very long time. So the initial infection is you're going to have mono-like symptoms. Like I said, it's going to be kind of like a virus. You're going to have high levels of virus in your body. You're not going to have a bunch of antibodies yet. So here we are, initial infection, okay? In the second phase, the viral numbers will begin to drop. All right, so you think you're getting well. Your antibodies begin to disappear. All right, so but your CD4 T cells actually start to decrease in number, and this takes a very long period of time, and so then you're going to be asymptomatic during this time for many, many years. It can last 2 years up to 15 years. Now, you may have some swollen lymph nodes, or you may have some of the Kuplik spots in your mouth, the canker sores, but that's going to be about it. So during the mid to late asymptomatic period, the number of T cells is just going to keep dropping, okay? And so this is the T cells up here, all right? And so it's just slowly, steadily decreasing until you get to a certain threshold point, all right? And you're going to decrease faster in the second half. And then right here, when you get to 200, that is when you are now considered to have AIDS. Once those T cells drop below that level, AIDS results, okay? So even though your antibody levels can stay high, your virus is still proliferating in your body, and your T cells are basically going to be shot. You're not going to have any T cells anymore. And those T cells, of course, are a very important part of your immune system. All right, and so here are some of those things that they see that were initially very perplexing, like having tuberculosis. You know, a young man in his 20s should not have tuberculosis, or pneumocystis pneumonia, as I was saying. Cryptococcosis. All right, so for the skin and mucous membrane and the eyes, you can see Kaposi's sarcoma, herpes simplex, as I said, mouth ulcers. That lasts longer than a month, and cytomegalovirus. All right. In the nervous system, you can have encephalopathy, lymphoma, and toxoplasmosis in the brain. The cardiovascular and lymphatic system, which is the systems we are in. You can see the coccidiomycosis, cytomegalovirus that can affect your liver and your spleen, histoplasmosis, Burkitt's lymphoma, mycobacterium, more fungi, mycobacterium tuberculosis, so fungal tuberculosis, salmonella, and you just start wasting away, all right? Respiratory tract, you can have yeast infection in the lung. That's your candidiasis. So yeast infection in your lung. That just doesn't happen in a normal, healthy person. Your body doesn't allow that. That's an opportunistic infection. Herpes simplex of the bronchitis and pneumocystis. All right, Mycobacterium avium, you don't see that in healthy people, all right? There's your pneumocystis pneumonia by Jarovecki, cryptococcosis. You can have yeast in your throat even, okay? And then you can also see herpes simplex in the GI and reproductive tract, all right? So those are some of the classic diseases and opportunistic, I should say, pathogens here that you see in a patient with AIDS. So HIV is this enveloped RNA virus. You can see it has these spikes here. These are going to be GP120 spikes. There is the CD4 receptor on the host cell along with the CCR5 co-receptor. These two are important. They have found a few people are actually resistance to AIDS, and it's because of differences in the CD4 receptors, although we have not found a way to really utilize that for treatment yet. So these glycoprotein spikes help them, like I said, get into the cell. They can only infect the cells that have the CD4 and CCR5 receptors, all right? So this is why they get into the T cells. And then it's going to gain interest to other leukocytes by using the T cells, all right? So, you know, we have T helper cells and those types of things. So HIV is going to enter the mucous membrane of the skin. It's going to travel to the dendritic cells beneath the epithelium, and it's going to grow inside the dendritic cells. And then it's going to shed off and kill the dendritic cells as it does so. And then it's going to be amplified by macrophages, okay? So they're going to actually make it more of them. And it's going to infect and destroy those T4 and CD4 lymphocyte, monocytes, macrophages, and B lymphocytes all fall in that category. And so it docks to that receptor and creates cell fusion, and you just get one big infected cell. All right, so let's look at this cycle here. The virus is going to dock and attach to the CD4 and CCR5 cells, all right, and fuse with the cell. Once it is inside the cell, it is going to use that reverse transcriptase to convert its RNA into double-stranded DNA, okay? So it's going to have that done, all right? And that is going to have a complementary strand here that's going to become the double-stranded DNA. It can cause a lytic infection initially, but it will often go ahead and enter a latent period in the nucleus of the host cell and just sit there for a while. As it does that, it's going to integrate its DNA into the host DNA. And so this latency is why we have such a long period, often 10 to 15 years, before somebody really starts to get sick. After that period stops, you're going to have some activation that's going to stimulate the cell and cause reactivation of the genes, and it's going to start producing the viral mRNA. Okay, so now we've got viral mRNA copied. And then the HIV mRNA is going to be made into components to make the virus by the cell's own machinery. All right, so again, viruses use the machinery of their host cells in order to put together new virions. So that's what we've got. We've got your little assembly here, and then you're going to have your maturation, remember, and then you're going to have your release. Okay, and so it's going to bud. The mature viruses will bud and lyse and leave the infected cell. So HIV is going to be transmitted primarily through sexual intercourse or transfer of blood products. And it's all about how many virions there are per unit of whatever that bodily fluid is. So there's a whole lot more virions in blood than there is in, say, saliva. That's why it's very, very difficult to catch HIV from saliva. Babies can be infected during birth or through breastfeeding. Unfortunately, that does happen quite a bit. It is similar to the Hep B virus, except it doesn't survive very long outside of the host. And so this is why you don't necessarily catch it after sitting on a toilet seat. Okay. It is very sensitive to disinfectants. Healthcare workers need to be very aware of the fluids that they come in contact with. People that are known to have HIV, it should be posted, at least in their file. And so you have to take extra precautions. You should always take extra precautions when you come into contact with blood anyway. But especially during childbirth, there are other invasive procedures, okay? Amniotic fluid, synovial fluid, spinal fluid, semen, vaginal secretions, these can actually harbor free viruses and infected white blood cells, okay? So we can get the virus from urine, tear, sweat, and saliva, although those are not considered sources of infection because the viral load in those particular fluids is so low. It's possible, but not likely, okay? Breast milk contains a large number of leukocytes. So neonates that have escaped infection prior to and during birth can actually still become infected via breastfeeding, which is not a good thing. So since the beginning of the early AIDS epidemic in the early 1980s, 35 million people have died of AIDS worldwide. 1.2 million of those in the U.S. We have seen decreases since 2005 in new infections. One is due to education, global initiatives at getting out contraceptives and educating. And it's not just whether or not people use contraceptives. They also have to overcome societal beliefs and different things about using those types of things, and then have access to them to protect themselves as well. So that there's lots that goes into that. So more people in the developing world are going to be receiving treatments because everybody's kind of getting together and trying to help. As I said before, in most parts of the world, heterosexual intercourse is actually the primary mode of transmission. In the industrialized world, that rate of heterosexual infection has actually started to increase. Even though we saw it here in the U.S. enter in a different way, it has now increased. The highest rates are among adolescents and young adult women. Women, because they are more prone to catching it just due to the fact of the way our anatomy is put together. And young adults, because they don't always practice safe sex, to be honest. Thrill-seeking behavior, that type of thing. They don't think it'll happen to them. In the United States, more African Americans are representing percentages of the population. I don't really know why that is, unless, again, it has to do with education and knowing to use those contraceptives. So 12% of the population, but account for 45% of new HIV diagnosis. And so that is something we need to work on. We need to combat that and figure out why is there a higher percentage there and what can we do to help prevent it. About 1% of people who are antibody positive for some reason do not develop AIDS. And so we don't really quite understand that. And they are definitely studying these people to learn what we can from them and to help people that have it and are sick keep their immune system working. And so these people are called non-progressors. They have a functioning immune system, and for some reason it's just not spread. And then there are those, like I said, that are basically immune because their CD4 receptors and CCR5 receptors have enough differences that it's not able to invade. So studies for genetic engineering, that type of thing, are very important here. So if you have tested positive for having the virus, then you have an HIV infection. If you get below the 200 level on the T cells, then you have AIDS, okay? Viral testing is based on finding the antibodies specific to the virus, okay? You can have false negative results. People that are negative but feel they have been exposed need to be retested in about 3 to 6 months. Very, very important. A positive test is kind of a screening test, so then it needs to be followed up with a more specific type test, okay? Which is going to be something like looking for the actual nucleic acid, a direct test, okay? In the U.S., diagnosis with AIDS is going to require testing positive for the virus and meeting one of these 3 criteria. Your CD4 cells, like I said, drops below 200, or they are less than 14% of your total lymphocytes, okay? And you also, or I should say, experience one or more of those AIDS-defining illnesses, those opportunistic infections that we just don't see in a young person. So how do we keep from getting AIDS? Well, that is to avoid sexual contact with an infected person. So that is also going to be really important to practice safe sex, to assume that every partner is infected unless proven otherwise. Safe sex meaning using condoms, both male and female. And just avoid having sex sometimes might be a good way to avoid getting it. You can't get it if you're not doing it, right? Also, avoiding IV drug use and sharing needles, okay? If you don't know, then you should assume that they could have it, okay? We do have different drugs that can treat HIV, although we do not have a cure, not yet. We have not been able to find a cure for this. We usually give a combination or cocktail of different drugs from different classes, okay, because it has a very high mutation rate, and so it becomes resistant to different medications, and so they give a cocktail of different medications here, okay? And so this has greatly improved the quality of life for people. All right, we have seen huge strides and advancements in medication. All right, although there are many areas of the world where the medications are just too expensive. Okay, so we need affordable and practical delivery mechanisms for these different drugs. So some of the drugs we use are AZT, DDL3TC. These are going to act by inhibiting that reverse transcriptase, okay? And so you can't convert the RNA to DNA, and then it can't be inserted into the viral genome. I'm sorry, into the host genome. And so that's their mechanism of action, okay? Then we have protease inhibitors that can actually plug into the active site on HIV protease, okay? And so that enzyme is needed to produce smaller units of proteins to make copies of the HIV, okay? So if you're blocking the enzyme, the proteins can't be made, and so you can't make a functioning viral unit, all right? Then you have integrase inhibitors, and that's a class of drugs that attach to the enzyme that's required to actually splice the double-stranded DNA from HIV into the host genome, okay? And again, that's going to prevent formation of mature viruses, okay, to leave the cell. So those are the three ways these different medications work in a very general sense.